Welcome to our deep dive today. We're focusing on elective transjugular intrahepatic portosystemic shunt, TIP ES, specifically in patients with cirrhosis. Our aim is to really get into the weeds, looking closely at the recommendations and the evidence behind them, particularly relevant for those of you managing these patients in hepatology. We'll be drawing heavily from the clinical practice guidelines developed by the European Association for the Study of the Liver, EESL.
Exactly. And these ESL guidelines, they weren't just thrown together. They involved a nominated chair, an expert panel of 8 members, carefully balanced for gender, geography, expertise, the work.
Right, ensuring broad representation.
Absolutely. Plus, there was a Delphi panel. 33 physicians with diverse backgrounds, even including 2 patient representatives, were involved, all following ESL's standard operating procedure.
So it's a very rigorous process underpinning these guidelines.
Definitely.
And when we talk about the evidence supporting these recommendations, what system are they using?
They use the Oxford Center for Evidence-Based Medicine levels. So level 1, that's the top-tier systematic reviews of randomized controlled trials, the strongest evidence we have.
Okay.
Then you have level 2 and 3, which include things like individual RCTs, observational studies, cohort studies, and so on. It gives us a clear hierarchy for understanding how strong the evidence is for each point.
Got it. So let's start at the beginning. A patient with cirrhosis is potentially heading for an elective TPS. What's the first step in the evaluation?
Well, the guidelines make a strong recommendation. Level 5 evidence, 96% consensus for a really attentive history and physical exam.
Focusing on anything specific.
Yes, specifically looking for any signs of overt hepatic encephalopathy, HE, past or present, and also any clues pointing towards cardiopulmonary dysfunction. It's about spotting those potential red flags early on.
Makes sense. And what about lab work?
Also strongly recommended level 5, again, 94% agreement. You need the basics: INR, platelet count, hemoglobin, and a comprehensive metabolic panel.
Why those specifically?
They help assess bleeding risk, the extent of liver dysfunction, renal function, basically painting a picture of the patient's overall status. And crucially, you use these to calculate prognostic scores like MELD or Child-Pugh.
Are other scores like FIPS mentioned?
They are, yes.
Yeah.
The guidelines note that other scores, like FIPS, the Freiberg Index, or MOTS, might also be considered to refine that risk assessment further.
Okay. Now, are there situations where elective TIPS is just, well, off the table? Absolute contraindications?
Yes, definitely. And these are all strong recommendations, backed by level 2 evidence and strong consensus, around 94% agreement for each.
Shows.
Severe cardiac dysfunction, whether it's right or left-sided heart failure. Also, moderate to severe pulmonary hypertension that's defined as a mean pulmonary artery pressure over 45 mmHg on a right heart cath, even after trying medical therapy.
Right. Putting a shunt in with that kind of cardiac or pulmonary pressure seems very risky.
Extremely risky. Other contraindications include untreated severe valvular heart disease, any uncontrolled systemic infection or sepsis. That was a definite no-go.
Yeah.
Severe or refractory overt HE, especially if there isn't an intervenable spontaneous shunt you could potentially treat instead. Also, unrelieved biliary obstruction, and finally, any physical lesions in the liver that just technically prevent creating the TPS tract.
It really highlights the need for careful selection. The guidelines mention a multidisciplinary team approach, too.
Absolutely crucial. They emphasize this point. The pre-TPS assessment really needs input from hepatology, interventional radiology, cardiology, maybe others too, like transplant surgery, nephrology, depending on the patient. Table 3 in the source document actually details this collaborative approach.
Okay, let's dig into that cardiopulmonary evaluation a bit more. What tests are specifically recommended?
A comprehensive transthoracic echocardiogram is strongly recommended. That's level 2 evidence, strong consensus. It gives vital info on systolic and diastolic function, valves, right atrial pressure, right ventricular systolic pressure, the whole picture.
And ECG?
Yes. A 12-lead ECG is also strongly recommended. Level 5 evidence, mainly to screen for underlying issues like ischemia or arrhythmias.
What about those natriuretic peptides, BNP and NT-proBNP?
They may be considered. It's a weaker recommendation, level 3 evidence, but with high agreement, 97%. The idea is they can help with cardiac risk stratification.
Why is the echo considered so critical here?
Well, it's all about assessing the risk of cardiac decompensation after the TPS. Patients might have underlying sort of subclinical cirrhotic cardiomyopathy.
Right.
And TPS itself creates this immediate hyperdynamic circulatory state, putting extra stress on the heart. The echo helps identify pre-existing issues and gauge if the heart can handle that hemodynamic shift.
And the BNP levels, what's the potential significance there?
There's some level 3 evidence suggesting lower pre-TPS levels. Maybe BMP below 40 pgml and T-proBNP below 125 pgml might correlate with a lower risk of post-tip test cardiac problems. Still emerging data, hence the weaker recommendation.
Okay.
Also, assessing baseline RV indices on the echo, things like RV systolic pressure, TAPSE, RV strain, is important for gauging that cardiopulmonary decompensation risk.
We touched on pulmonary hypertension being a contraindication. Can you elaborate on the concerns?
Sure, if a patient already has significant pulmonary hypertension, like a mean PA pressure over 45 millimilli Hg, creating a TIP PS is really risky. It can precipitate right heart failure.
Mm-hmm.
Studies show TIP PS causes an acute jump in right atrial pressure, even in people without pre-existing pulmonary hypertension, maybe 3 to 5 millimilli Hg. And importantly, an elevated REP before TIPIAS is linked to worse long-term survival and more cardiac decompensation afterwards.
So, a key factor to assess, what about tricuspid regurgitation, or TR? That's pretty common.
It is. And you need to figure out why it's happening. Is it just volume overload, which might improve with diuretics, or is it pressure overload from pulmonary
How
hypertension?
does that distinction matter?
Because if it's functional TR from chronic volume overload leading to RV dysfunction and annular dilation, that might be a contraindication unless you can fix the underlying volume issue.
Mm.
And also, they note that even asymptomatic aortic stenosis is strongly linked to post-TIPS cardiac decompensation.
Okay, shifting gears to the renal side. What's the focus there?
Strong recommendation, level 3, 100% consensus to assess serum creatinine and GFR, estimated or measured.
Is there a GFR cutoff below which TPS is contraindicated?
Interestingly, no. The guidelines state weekly recommended, level 5, but full consensus that there's no absolute cutoff for renal function, like a specific creatinine level, CKD stage, or even needing dialysis. That's an absolute contraindication.
But renal dysfunction is still a risk factor.
Oh, absolutely. It's associated with worse outcomes.
Yeah.
So it's not an absolute no, but it definitely factors heavily into the risk-benefit calculation for that individual patient.
And the hematologic side, any hard stops based on INR or platelets?
Again, no absolute cutoffs are supported by current evidence for things like INR or platelet count. The evaluation involves looking at prior bleeding history and the current numbers, of course.
What about fibrinogen?
Low fibrinogen, say under 100 milli-GDLO, has been linked to higher bleeding risk in critically ill cirrhotic patients, but a causal link isn't firmly established. So routine correction before TIP test isn't recommended.
Hepatic encephalopathy, HE, is always a major concern with TIPS. How do the guidelines suggest assessing this risk beforehand?
It's multifaceted. A strong recommendation, level 2 evidence, is to thoroughly assess the history of any prior overt HE, how frequent, how severe, how it responded to treatment.
Okay.
They also suggest considering testing for covert or minimal HE, things like the psychometric HE score, encephalabs droop, or critical flicker frequency testing.
Why test for covert HE?
Well, it's for prognostication and to help the discussion with the patient. It's a weaker recommendation, level 3, but it helps frame the risk. We know covert HE is linked to a higher risk of overt HE post-TIPS and impacts daily function.
Does finding covert HE mean you should treat it before TIPS?
Currently, no. There's no data supporting pre-TIPS treatment of covert HE with lactulose or rifaximin.
What other factors go into the HE risk assessment?
Several things. The severity of the underlying liver disease itself, hyponatremia, older age, sarcopenia, that's muscle-wasting renal failure, and the presence of large spontaneous portosystemic shunts, or LPSS.
Right, those big natural shunts.
Exactly. This assessment is strongly recommended, level 2 evidence. Many of these are risk factors for HE, even without TIPS, of course. The overall risk assessment helps guide that crucial pros and cons discussion with the patient. Generally, lower Child-Pugh and MELOD scores mean lower H risk.
Moving on to imaging for planning the procedure itself, what's required?
Cross-sectional multiphasic imaging CT or MRI with a good look at the portal venous phase is considered mandatory. That's a strong recommendation, level 5, 100% consensus.
Why is that specific imaging so important?
While it might not directly impact technical success rates, it provides crucial anatomical information for planning the puncture, choosing the approach, and anticipating potential difficulties.
Does the standard liver ultrasound for HCC screening suffice?
Often, the cross-sectional imaging done for HCC screening already includes the necessary portovenous phases needed for TIPS planning. So yes, it can sometimes serve both purposes.
Is there a specific time frame needed between the imaging and the TIPS procedure?
No defined optimal timing. But if good cross-sectional imaging was done within, say, the last 3 months, a Doppler ultrasound might be enough for a final pre-procedural check of the vessels.
what if the patient's cirrhosis has a treatable cause, like Hep C or alcohol use? Should TIPS be delayed while that's treated?
The recommendation is to treat the underlying cause to optimize outcomes, definitely. But crucially, the guidelines strongly recommend not delaying the TIPS procedure just because the cause is treatable. There's no evidence supporting a delay.
Okay.
Treating the underlying cause, viral hepatitis, ALD, MASLD, AIH, can improve HVPG and portal hypertension complications over time, which is beneficial long-term, but it shouldn't hold up an indicated TIPS. That's level 5, strong recommendation, 94% agreement.
And finally, before elective TIPS, what about evaluation for liver transplant? Should everyone get a formal workup?
Routine pre-TIPS test transplant evaluation isn't recommended due to insufficient evidence. That's level 5, strong recommendation, 90% consensus.
But collaboration is key.
Absolutely. Close collaboration between the TIP-ESS team and the transplant center is essential to anticipate the potential need for LT on a case-by-case basis. Patients getting TIPS for refractory ascites or variceal bleeding do have indications for transplant evaluation, but not all will be suitable candidates.
Okay, let's pivot to TIPS-S specifically for variceal bleeding. What about salvage or rescue TIPS? When does that come into play?
This is for acute situations, either failure to control the initial bleed or early rebleeding within 5 days despite standard therapy. That's when salvage or rescue TIPS should be considered. It's a strong recommendation. Level 3 evidence, 93% consensus.
Is there a difference between salvage and rescue?
Subtle distinction, yes. Rescue TIPS is typically for rebleeding within 5 days after you initially got control endoscopically. Salvage TIPS is when endoscopy wasn't possible or just failed outright to stop the bleeding.
Are there times when even salvage rescue TIP-ES is too risky?
Yes. Generally not recommended if the MELD score is over 30 or lactate is over 12 millimol or the patient have ACLF grade 3B. These suggest a very poor prognosis, especially in non-transplant candidates. That's a weaker recommendation, level 3, but strong consensus.
Though some exceptions might exist.
Potentially. Some studies hint that preemptive TIPS, or P-TIPS, might benefit even some severe cases, like certain child PUC patients, or those with ACLF triggered by the bleed itself, or HE present at the index bleed. It requires careful judgment.
Now, what about preemptive TIPS, the strategy of doing it early in high-risk patients?
Right, P-TIP-ES. This should be offered within the first 72 hours to improve survival in specific high-risk patients.
Which patients qualify as high risk for P-TIP-ICS?
Those with child QB score over 7 and active bleeding seen on endoscopy despite drugs, or child PUC patients with a score less than 14, or anyone with an HVPG measured over 20 millimol Hg at the time of bleeding. This is very strong recommendation. Level 1 evidence, 97% consensus.
That 72-hour window seems critical. What if bleeding isn't controlled immediately while waiting for TIPS?
You bridge them. Balloon tamponade or an esophageal self-expandable metal stent, a THEMS, should be used to control bleeding until the TIPS can be placed.
What if the 72-hour window is missed? Is P-TIP-ES still an option?
Maybe. Selected patients might still benefit after 72 hours, but it's a weaker recommendation. Level 4, 100% agreement. Referral to an expert center is advised in those cases. And you still need the basic liver function tests and imaging beforehand.
You mentioned earlier a potential concern about cardiac decompensation with P-TIP-ES in one study?
Yes, that's right. While the survival benefit is clear in high-risk patients, one study did find a higher rate of acute cardiac failure in the P-TIP-ES group, even though most had normal baseline echoes. The factor linked seemed to be a very high portal pressure, over 20 millimol Hg.
But other studies didn't show this.
Correct. Other key studies didn't report increased cardiac deaths, so the data on this specific cardiac risk with P-TIP-ES is a bit limited and perhaps conflicting. We don't have universal recommendations for enhanced cardiac assessment just for P-TIP-ES candidates yet.
Okay. What about secondary prophylaxis? After a patient has had their first bleed, is TIP-ES the go-to over standard beta blockers and banding?
No, standard secondary prophylaxis that's non-selective beta blockers plus endoscopic band ligation, NSBB plus EBL remains the first-line treatment. That's a strong recommendation, level 5, 97% consensus.
So TIP-ES is reserved for failure?
Generally, yes. TIP-ES should be considered if standard secondary prophylaxis fails. However, there's a nuance. TIP-ES might be preferred even after a first bleed if the patient doesn't meet high-risk criteria, but does have grade 2 ascites or portal vein thrombosis. That's a weaker recommendation, level 2, but full consensus.
What about leading from less common sources like gastric varices, ectopic varices, or portal hypertensive gastropathy?
So TBS has a role here, too. For certain types of gastric varices, specifically type 2 gastroesophageal or type 1 isolated gastric varices, TBS could be a reasonable first-line alternative. That's level 3, weak recommendation, 100% consensus.
And for gastropathy?
For portal hypertensive gastropathy that's refractory to standard treatment, TBS may be considered. Evidence is weaker, though. Level 4, weak recommendation, 93% consensus.
The guidelines mention Sarin's classification for gastric varices. Why is that important?
It helps guide treatment. GOV1 varices, which are extensions of esophageal ones, often respond like esophageal varices, but GOV2 or IGV types often have different drainage, like large gastrorenal shunts.
And how does that affect TPS strategy?
In those cases with large shunts, TPS combined with embolization of the shunt seems more effective than TIPS alone. BRTO is another key option for varices draining into the renal vein. You really need imaging to understand the anatomy.
What about ectopic varices?
TPS with embolization can be effective, but the evidence base is limited. Same for portal hypertensive gastropathy. Evidence mostly comes from case series showing some benefit with TPS.
All right, let's move to ascites and related issues like hepatic hydrothorax and HRS. For refractory or recurrent ascites, when should TIPS be considered?
Early. The guidelines strongly recommend discussing TIPS early for patients needing repeated large volume paracentesis, LVPs, despite optimal medical therapy. This is top-level evidence. Level 1, strong recommendation, 100% consensus.
Why so strongly recommended?
Because refractory ascites has a grim prognosis, about 50% one-year survival. Meta-analyses show TIPS improves 2-year survival compared to just LVPs. The Bovino 7th consensus suggested maybe 3 LVPs in a year as a trigger to consider TIPS. Plus, it's been found to be cost-effective, improving quality-adjusted life years.
And for hepatic hydrothorax, the fluid in the chest cavity.
TIPS may be considered. It's a weaker recommendation, level 4, consensus 100%. A meta-analysis showed complete control in 56%, partial in 18%, but there was an 18% 45-day mortality post-TIPS.
So not a slam dunk.
Not yet. A propensity-matched study showed similar survival with or without TIPS. There's an ongoing trial, Liver Hero, comparing TIPS to standard care, which might give us clearer answers.
What about hepatorenal syndrome, specifically HRS-AKI, the acute form?
For HRS-AKI, TIPS is not currently recommended to reduce morbidity or mortality. There's just insufficient evidence, no RCTs in this setting. It's a level 4, weak recommendation against it, 97% agreement.
But what about the less acute form, HRS-NACI?
For HRS-NACI, TIPS may be considered to reduce morbidity and mortality. Again, level 4, weak recommendation, 96% agreement. Some studies suggest it improves hemodynamics and renal function.
Any stronger evidence?
A Cochrane review showed possible kidney function improvement, but no clear mortality benefit. A recent survey suggested lower in-hospital mortality with TIPS for HRS, but it didn't specify the type and could have confounding. So still an area needing more research.
Okay, let's talk technical aspects of actually placing the TIPS. Where should this procedure be done?
Ideally, in tertiary centers with full multidisciplinary backup hepatology, IR, cardiology, surgery, ICU, the works. There's a suggestion that centers doing at least 20 TPS per year might have better outcomes.
And the operator?
Needs to be a trained provider experienced in TIPSes and managing its complications. There's no set number of procedures to define experience, but competency should be attested after supervised training.
How is the portal vein actually accessed during the procedure?
Real-time ultrasound guidance, either transabdominal or intravascular, is suggested. It's a weak recommendation. Level 4, 100% agreement, aimed at reducing puncture complications and radiation dose.
What if there's severe thrombosis or cavernoma?
If the standard transjugular approach fails, more complex combined approaches might be needed, transjugular transhepatic, transsplenic, or even transmesenteric. Similar success rates are seen in liver transplant recipients versus native livers, though alternative approaches might be needed more often post-transplant.
What kind of stent should be used? And how much should it be dilated? What's the target pressure gradient?
Strong recommendation, level 2, 100% consensus. Use EPTFE-covered stents extending to the hepatic vein IVC junction. They have better patency and outcomes than bare metal stents.
And the diameter?
Use the smallest diameter that achieves an adequate hemodynamic response, generally aiming for a post-procedure portal pressure gradient, PCPG, below 12 mmHg. Overshunting causes problems like HE and heart failure.
Is underdilatation ever considered?
Yes, some suggest underdilating to 6 mm might reduce post-TIPS HE without increasing bleeding or thrombosis risk. Staged placement, starting small, is often advised. The target PCPG is definitely 12 millimole Hg for variceal bleeding.
What about for ascites?
The correlation is less clear, but aiming for 12 millimole Hg or a 60% reduction from baseline is often suggested. And you must measure the PCPG, the difference between main portal vein and IVC pressure at the shunt outflow at the end. Right, atrial pressure isn't a substitute.
Should collateral vessels like varices be embolized routinely during TPEs?
It's debated. An older meta-analysis suggested embolization reduced rebleeding risk, but it was mostly observational data with mixed techniques. A more recent study using only modern covered stents found no benefit from routine embolization.
So the current thinking?
Maybe consider embolization if large varices persist after TIPS placement. Glue plus coils might be better than coils alone.
What about embolizing those large spontaneous shunts, the LPSS, to prevent HE?
Some studies, mainly in Asian populations with Hep B, showed embolizing LPSS during TIPS reduced subsequent HE. But whether this applies broadly, or if any shunt should be prophylactically embolized, needs more proof. The general approach now is medical prophylaxis first, controlled stent expansion, and reserve LPSS embolization for persistent HE post-TIPS.
Should abnormal coagulation tests be corrected before elective TIPS?
Routine correction isn't recommended for non-bleeding indications. Level 4, weak recommendation. There isn't enough evidence that correcting INR or platelets improves outcomes or reduces bleeding risk. It's an individual decision based on the patient and local protocols.
And peri-procedural antibiotics, routine or not?
Not systematically recommended for elective non-bleeding TIPAS. Level 4, weak recommendation, 97% consensus. Infections are infrequent but can be severe, and older RCT with bare stents are no benefit. Maybe higher risk if there's been prior biliary work. Again, case by case, and follow local protocols.
Okay, the TIPAS is in. How do we follow up? How is clinical effectiveness monitored?
It depends on the indication. No rebleeding for varices, resolution of ascites hydrothorax for fluid issues. But any recurrence of portal hypertension complications should make you question effectiveness.
Any specific follow-up schedule?
Clinical follow-up at 4 to 6 weeks, then every 3 months for the first year, then every 6 months. For patients who had TIPES for PVT recanalization, a CT scan 2 to 4 weeks post-procedure is useful to check the stent effect.
How do we watch for TPS dysfunction, the shunt itself failing?
Suspect it if portal hypertension symptoms recur rebleeding, new or worsening ascites. That's a strong recommendation, level 4. Doppler ultrasound is the first-line tool for surveillance, another strong recommendation, level 4.
When is angiography needed?
Only if there's clinical or ultrasound suspicion of dysfunction, not routinely. That's level 4, strong recommendation, strong consensus. A 50% stenosis is often used to define dysfunction, but there's no precise definition. Remember, for bleeding, the goal PPG is 12 millimole Hg. For ascites, it's less clear, but 8 millimole Hg increases HE risk.
What about cardiac monitoring after TIPS?
Clinically assess for overt HE using West-Statement criteria, strong recommendation, level 4. If you suspect cardiac decompensation, get a transthoracic echo. If that shows problems, or the patient isn't responding, consider it a right heart cath. Also strong recommendations.
When does the TPS need revision?
First, rule out other causes like infection, liver cardiac failure, or severe HE. If it is shunt dysfunction, revision dilation, restenting, maybe collateral embolization should be done ASAP, especially if they're bleeding. Strong recommendations, level 4. For ectopic variceal bleeding with TPS dysfunction, consider embolizing the varices along with the revision.
What if the problem is overshunting too much flow through the TPS?
If it causes acute liver or cardiac failure and there aren't significant competing collaterals, you should reduce or occlude the TPS. Same for chronic, severe, refractory HE without competing collaterals. These are strong recommendations, level 3.
What if there are competing collaterals?
Embolize those before reducing or occluding the TPS. Another strong recommendation, level 4. And in all these severe overshunting cases, liver transplant evaluation should happen in parallel.
What about managing other things post-TPS, beta blockers?
Discontinue NSBBs if the final PCPG is 12 millimole Hg, unless there's another reason to keep them. Consider starting or continuing them if PCPG is 12 millimole Hg. Strong recommendation, level 4.
Routine endoscopy?
Not usually. But consider 3 to 6 months post-TPS if it was for variceal bleeding and PCPG is 12 millimole Hg, or if dysfunction is suspected but the shunt can't be revised. Strong recommendation, level 4.
Diuretics?
Yes. Close monitoring and retitration are recommended for ascites or high cardiac risk patients, assuming kidney function allows. Strong recommendation, level 4.
Anticoagulation for TPS patency?
No routine recommendation for anticoagulants or antiplatelets, just for patency. Level 4, weak recommendation.
And HCC surveillance.
Follow standard guidelines, typically biannual ultrasound. MRI is feasible with a tip yes in place. Strong recommendation, level 3.
How is HE managed specifically after TIPS?
Lactulose is first line for treatment and prevention. Strong recommendation, level 5. Rifaximin can be added if lactulose fails or used instead as intolerant. Weak recommendation, level 4.
Should rifaximin be used prophylactically?
It may be considered before non-urgent tips even without prior HE, level 3, weak. It should be considered in those with prior HE, level 2, strong. If age becomes refractory despite meds, shunt reduction occlusion is an option, but remember the risks of recurrent portal hypertension, so LT evaluation is crucial.
What about nutrition and sarcopenia?
Nutritional counseling, ensuring adequate energy, protein, and exercise are important for all cirrhotic patients. Strong recommendation, level 5. However, routine imaging assessment for sarcopenia before tips specifically to reduce HE risk isn't recommended due to insufficient evidence. Level 4, weak.
But nutrition still matters.
Absolutely. Nutritional status is prognostic. If sarcopenia is diagnosed, interventions like high-energy protein intake and late-evening snacks should be considered before and after tips, preferably orally.
Finally, let's touch on tips in the context of HCC and liver transplantation. Are the contraindications different if a patient has HCC?
For patients within transplant criteria, the absolute contraindications are the same whether they have HCC or not. Advanced HCC as a relative contraindication needs case-by-case assessment based on cancer prognosis and options.
Are there specific HCC scenarios where TIPS is definitely not advised?
Yes, creating a TIPS through a tumor mass or if there's tumoral portal vein invasion is not recommended. Level 3, strong recommendation. However, sometimes TIPS might enable oncologic treatment in patients with advanced portal hypertension. Careful selection and expertise are key.
Can HCC be treated if a patient has a TIPS?
Yes, ablation and systemic therapies are generally feasible and safe with good performance status, Child-Pugh ABE, and smaller tumors. Level 4, weak. TACE post-TIPS needs caution due to reduced portal perfusion. Be super selective if used. Level 5, strong. Radioembolization might be preferred over TACE to limit ischemia. Level 4, weak.
Does TIPS have a role before transplant?
It may be considered to decompress the portal system, reduce collaterals, maybe lessen surgical bleeding. Needs discussion with surgeons, especially regarding stent extension. PVR tips can also recanalize thrombosed portal veins, potentially enabling LT.
And TIPS after transplant?
Main reasons are recurrent portal hypertension, ascites, varices, or hepatic venous outflow obstruction. It seems less effective post-transplant compared to native livers, often providing only marginal benefit without retransplantation. Feasibility in partial grafts seems similar to whole grafts. So to wrap up, this deep dive really underscores that managing patients for elective TIPS involves a very detailed assessment across multiple organ systems: liver, heart, lungs, kidneys, brain. The decision-making has to weigh the indication, the risks, the benefits, and all the technical nuances.
Right. And that multidisciplinary approach is clearly not just a suggestion, it's fundamental to navigating these complexities and tailoring the plan to the individual patient.
Exactly. And it's a dynamic field. Research is ongoing, constantly refining our understanding and hopefully improving outcomes. For anyone wanting even more detail, the supplementary data linked to the EASL guidelines is incredibly comprehensive.
Absolutely. So thinking about all these guidelines and the complexities we discussed, what stands out to you as a really significant unanswered question in the TIPUS and portal hypertension field, something that truly needs more investigation?